Welcome to Human School. I'm your host, Dr. Patil Armenian. After 4 years of college, 4 years of medical school, 4 years of residency, and 2 years of fellowship, I thought I was done. I did my time, got my degrees, and now I was just gonna live life. Well, think again. Some of my greatest schooling has come after my formal education was complete, and it keeps on coming. Join me at Human School, where we can learn together. I'm an emergency physician and medical toxicologist working at a large teaching hospital in California. I'm also a mom, wife, sister, daughter, and friend. Whether you work in healthcare or not, you too lead a busy life. Together, let's work on how we can thrive in all of our real-world roles. On this podcast, we'll dig deep into what it means to constantly learn and evolve, to be human. Every other week, I'll share some of my personal stories, interview inspiring people, and offer tools to help you learn more about yourself. Being on the front lines in the ER, you learn a lot about life and death. And though my philosophies were born in a busy emergency room, they can apply to anyone trying to live a joyful life here on Earth. Please listen, share, and subscribe to this podcast, available on Apple Podcasts, Spotify, or wherever you get your podcasts. Follow me on Instagram at Human School Podcast, and feel free to let me know what topics or guests you want to hear about. And if you like the podcast, don't forget to rate and review it. Hi, everyone, and welcome to Human School. This is my first episode, so thanks for listening. I've been thinking about starting my own podcast for a long time, so here we finally are. We're going to be discussing topics I've learned from, I'm still learning from, speaking to mentors that have inspired me, and talking to those with techniques to help us navigate the hard things in daily life. This is completely different than the other podcasts I do with my friends Dr. Danielle Campaign and Dr. Sajan Bhakta, which is the American Ambulance EMS podcast, and that one's geared towards pre-hospital medical education. So if you're into that topic, please go listen to that one too. Now, I just didn't know where to start with my own podcast. But since at its core, this is about learning, the most natural place to start is by talking about the lessons I learned from one of my most influential mentors, Dr. Lori Weichenthal. If I just read her CV, it would take up this entire episode. It's astounding how much she accomplished, and with grace and a calming energy. Not just an academic emergency physician at UCSF Fresno, where I also work, Lori started the Wilderness Medicine Fellowship here, was the Associate Program Director for the Emergency Medicine Residency, and the Dean for Graduate Medical Education. And that's just the tip of the iceberg. Lori was my friend, colleague, and mentor all in one package. In the beginning of February, she died after living with a rare and aggressive cancer for over 3 years. And I say she lived with it because of all that she accomplished and continued to up until the few weeks before her death. The more I realize the impact she had on me over the last 17 years, the more I just really want to cry because she played a quietly pivotal role in so many things. She was the person there for my grand concept, smaller projects, personal ideas, and individual cases that shaped how I thought about myself and the world. She was actually the first person I met who did yoga and meditated, which is so surprising nowadays. And she wanted to teach that to everyone. Before every big meeting, like our annual department retreat, she would lead the team through a series of yoga stretches or a brief guided meditation. And we'd all chuckle at first, like, there goes Lori again. But we all respected her so much that we went with it. And by the end, inevitably, we all felt better. She was such a strong clinician and really just a badass in the ED that when she talked about things like wellness, yoga, meditation, and sleep cycles, we listened. It wasn't coming from somebody who couldn't hold their weight when shit hit the fan in the ER. It was coming from Lori. I just don't know if she knows what effect she had and if she knows how much I appreciate her and love her. Now, as physicians, sometimes it's easier for us to be in the clinical setting on the doctor side of things rather than on the patient side of things. And sometimes I just didn't know what to say when she was sick. During Halloween time this year, she was admitted to the ICU for sepsis, and we were able to talk in the early mornings when I would visit her. Her body was reacting really poorly to the chemo, losing her white blood cells, which made her susceptible to life-threatening infections such as sepsis. It seemed that she was tired of talking about her illness, so she kept asking me questions about my son, Cebu, about what I was up to, how I was doing. I wanted to be like, no, how are you doing? But we both knew that answer already. Somehow, during her entire illness, and even after she was released from that hospital stay, she continued to work as our Dean for Graduate Medical Affairs. That means she was the dean in charge of all the residency and fellowship programs. Normal people are challenged by that job in the best of circumstances, but Lori handled it all with both grace and firmness that our university needed. And I'll just say it's not easier dealing with someone's death when you already know they are dying. Death is death. The one thing that gives me a modicum of comfort is that she is no longer in pain, is no longer suffering. And the other is knowing the wide-reaching impact she had on so many. I have distinct things I learned from Lori, but also quiet lessons that sank in later. Ever since I started college, I feel like I've been on a hunt for mentors, and I've been so lucky to find amazing ones along the way. Mentors come in all shapes and sizes. Some are in your life for a long time, some only for the period of time when you needed their specific expertise. My primary mentor in college, and really now the rest of life, was Bernie Frischer. But I had others pushing me along the way, helping me to see possibilities in myself I didn't even know were there. In med school, I never had a solid connection with anyone, but took bits and pieces from senior residents and faculty along the way. Now, once I got to emergency medicine residency, that first year, which we call our intern year, was simply about survival. Then, at the beginning of second year, we were allowed to pick a formal faculty mentor. Now, at that time in our department, we only had 3 women on the emergency medicine faculty. It's actually really different now. Now, sometimes I feel like we have a majority of women. But at that time, we just had 3, and I chose Lori. She immediately set up a meeting time with me, which was afternoon tea at a local Victorian tea room. We got dressed up and went, which is a big deal for ER doctors, since we're pretty well known to wear exercise clothes, climbing clothes, hiking clothes, anything Patagonia at all times, maybe throw some North Face in there. We're pretty much the most casual out of all the medical specialties. Now, I don't even remember what we talked about during that first meeting, but I knew I'd picked a mentor with an open mind, that I could say anything to and she wouldn't think I was crazy. Just total open-mindedness. Lori did things that were not the norm. With her quiet but assured demeanor and immense respect from her colleagues, she got away with it. At the weekly EM morning conferences, she lectured on topics like sleep cycles and circadian rhythms. She gave us tips on how to rest and sleep as shift workers, a topic we'll get into more in future podcast episodes. I wouldn't even know how to sleep properly from the very beginning of residency if it hadn't have been for Lori. She led our big meetings, like I said earlier, our annual program retreat and faculty retreat with yoga stretches and guided meditations. And really, by the end, we would always feel better, and we were so grateful that she led us through those practices. She led weekly yoga classes on the hospital grounds, organized through the dean's office, and because she just did everything without making a fuss about it, the cutting edge became the norm. I didn't know that other EM residencies didn't have a certified yoga teacher or massage therapist in their faculty. I had no clue that every EM resident wasn't learning about sleep and how to sleep better in order to live better. I just took it for granted. One time I remember as a resident, I'd pulled my back, really due to a leisure-related injury from going to Tulum and resting in a hammock for too long. I know, completely ridiculous. But at work, we were in the doctor's charting area, and Lori just saw that I was in pain, I could barely move, and showed me a few quick yoga stretches to help my back. I told her, I can't do any of these. This isn't going to help. She told me to just do it when I got home and keep doing them as much as possible. It was a simple cat-cow and a few other stretches. Sure enough, it helped, and as someone who had never done yoga in any form, I was impressed and so grateful. I'd never met anyone who did yoga, and she just lent an air of credibility to it. I didn't go to any classes as a resident, I was just too busy with work. But the year after graduating emergency medicine residency, when I was a toxicology fellow in San Francisco at UCSF, I was overwhelmed with the workload and probably had some seasonal affective disorder from living in a foggy neighborhood where I never saw the sun. I felt like I had to do something, but I didn't know where to start. I wasn't going to quit fellowship. I had to work my shifts in the ED to make money as a fellow. I had to keep studying to learn a second specialty, medical toxicology. Meanwhile, I was still studying for my boards for the first specialty, emergency medicine. And then I thought about Lori. She multitasked between many jobs in the ED with such outward ease. At that time, she worked emergency department shift, was the assistant program director for the residency, did tons of published research, started the new wilderness medicine fellowship, and was on a bunch of hospital committees. She had more going on than I did. And I remembered that she did yoga every day. So then I immediately Googled yoga studios and found one that was walking distance from my apartment in San Francisco and went the next day. My first vinyasa yoga class was so difficult and I was extremely sore the next day, but I felt good and my mind was clearing up. After that, I went twice a week during fellowship, and I'm convinced that it saved me from burnout, quitting, being overall miserable. Since then, whenever I've had a particularly challenging period in my life, I start going to vinyasa yoga classes regularly, and it has been beyond helpful for my mind and body. Another day in fellowship, I was feeling particularly overwhelmed and told my wonderful co-fellow Derek that I needed a mental health afternoon. That was during our first year of fellowship, when we were in our office at the San Francisco Poison Control Center Monday through Friday, and expected to be there all day. However, after morning rounds were over, one person could easily handle the afternoon workload. Now, I loved working with Derek so much, and one of the things I loved the most was that we had the same working style. Like, we could be lazy and take a break, and then also work hard when we needed to. We were just on the same pace together. So I felt comfortable telling him that I was going to have a mental collapse and needed a break that afternoon. I'd never done that before or even thought about it, but I knew that I had to take care of myself better or I was never going to survive the double specialty lifestyle. I took off afternoon and went to Japantown to the Kabuki Day Spa. I don't even remember if I had a massage or what, but I do remember that for $25, you could use the steam room, sauna, hot tub, and cold plunge bath for as long as you wanted. I spent a few hours there and left feeling like a new person, ready to face my multitude of tasks. It was there that I began to formulate my idea of blocking out time in your calendar for yourself, another thing we'll be talking about a lot in future podcast episodes. If it wasn't for Lori, I don't know how fast I would have come to this realization. She really normalized the concept of taking care of yourself so that you can take care of others. And that she did. She cared for others so deeply, but this was rooted in a strong sense of wellness practices. Now let's flash forward to the end of September of 2020. Lori and I went on a walk, and this was peak pandemic, and she had already been through surgery and chemotherapy for her cancer. Her energy had improved to the point where she could do a 1-hour walk, so we masked up and chatted and went out on a trail in a local park. I wanted to pick her brain about the response to the COVID pandemic and the speakers at the latest ACEP meeting. Now, ACEP stands for the American College of Emergency Physicians and is our largest professional organization, and I'm proud to be a member of it. And that year, doctors Anthony Fauci and Deepak Chopra were announced as keynote speakers for the fall 2020 conference, with Fauci having top billing. Of course, this was a virtual conference since we know what fall 2020 meant, peak COVID pandemic. And shortly after it was announced, ACEP withdrew Chopra as a speaker due to massive backlash from ACEP members. So they were calling him a charlatan, appalled that any of his information would be presented as wellness for EM physicians. I was genuinely shocked by this, especially since it was the ACEP lecture I was most looking forward to that year. In the midst of the COVID pandemic, I was tired of the death and seriousness. I was surrounded by burnt-out physicians and PAs and nurses who saw no end in sight. Newsflash, we still don't. It's probably worse than ever in our departments right now. And I wanted to know if the organization was offering anything to help me and the masses of tired and burnt-out ER doctors cope with our reality. So I felt Chopra's talk might be a great antidote. In response to the cancellation, Chopra posted his lecture slides since he'd already made them. Of course, I looked at them and they didn't seem too controversial to me, but that's just my opinion. He was basically discussing the benefits of meditation, using multiple medical studies to back him up. He spoke about the benefits of yoga, and really about taking a pause and taking care of yourself. What was the problem here? I genuinely didn't realize that Chopra was still controversial since he is so mainstream. He was one of the authors on this following paper, published in June 2020 in the Journal of Alternative and Complementary Medicine. It was titled Meditation and Yoga Practices as Potential Adjunctive Treatment of SARS-CoV-2 Infection and COVID-19, a brief overview of key subjects. It was a very mildly written paper, gently broaching the topic of helping people physically feel better through meditation, certain yoga positions, and breathing practices. Was it and is it so scary for people to start talking about maybe how to feel better, how to boost your immune system, improve your own symptoms? The study was by no means discounting COVID-19. It wasn't talking about how to treat severe cases once they've set in. Really none of the COVID controversies. It wasn't saying, you have COVID, don't take meds or go to the hospital, just meditate. Like, absolutely not. And I would never condone that either. That's ridiculous. But I like the yes and approach, kind of like in improv comedy. Yes and, taking the best from cutting edge medicine and incorporating wellness practices that may help you too. In addition, what about the well-known fact that emergency physicians are tired? We are burning out in droves. We cannot ignore that elephant in the room. I don't know a single emergency physician now who doesn't talk about what else they could do on the side to keep them happy, because working just shifts is not enough anymore. So in this setting, is there no room for teaching some daily practices to improve our own health and well-being in emergency medicine so we can stay in emergency medicine? If we don't learn how to take care of ourselves better, how can we care for others in this high-pressure, high-volume situation? I felt that our biggest organization had really acknowledged that and then rescinded the support almost as soon as it was given. Because of Lori's influence, I just didn't think these ideas were cutting-edge concepts or even controversial, but it turned out that it was. During our long walk, we talked about this a lot, and she spoke about her meditation practice and how important it had been during her cancer treatment and still was. It was really useful because she reminded me of how far people had even come during her career, and that it wasn't worth my anger or frustration. She told me to keep going on whatever path this was that I was on. There would be a time when people would be ready to hear it, and she felt though helping yourself be better was scary and controversial to some, it was just because they didn't understand it yet. And I felt that even just that discussion was so immensely helpful to me. There's just so much that Lori taught me, but I'm going to narrow it down to 3 patient cases that served as goalposts at specific points in my life. The first case was when I was a baby second-year resident. Now, when you're in emergency medicine training, you don't start off seeing the sickest patients. You have to learn on the less sick patients and slowly graduate to taking care of the really sick ones. Emergency medicine residency programs are 3 or 4 years long, and my program, UCSF Fresno, was and is 4 years long. At that time, in the beginning of second year of residency training, we were finally allowed to start seeing the sickest of the sick in our resuscitation rooms. Now, this specific shift happened early in my second year, maybe my second or third time assigned to the resuscitation rooms. There were many things I had not seen before, and somehow I hadn't yet taken care of any head bleeds. That's blood inside the skull, pressing on or in the brain. It could be a hemorrhagic stroke, subarachnoid hemorrhage from a burst aneurysm, subdural or epidural hemorrhage from a traumatic injury, a bleeding tumor, or a host of other causes. What you need to know is that blood in the brain is never good. In fact, it is life-threatening. The other thing you need to know is that I questioned my decision to actually be a doctor and then to go into emergency medicine a lot up to that point. And we'll talk about that some more another day. It's interesting how certain shifts in the ER will have themes. And this was the theme of the day: head bleeds. In the course of 2 hours, I took care of 3 extremely sick patients with different types of head bleeds. I was bouncing from patient to patient, checking on their status, making sure the right tests and interventions got done, getting the specialists, the neurosurgeons on board. In the meantime, 2 of the 3 needed to be intubated, and with Lori at the bedside as my attending, we got it done quickly. For my sister, who's not in medicine, intubating is putting a breathing tube in someone's windpipe and hooking them up to a ventilator that helps them breathe. It's done in really, really sick, critically ill patients. Now, it was overwhelming dealing with so much critical illness at the same time, and I wasn't sure I was doing a good job, but I kept moving, kept doing tasks, seeing other patients, circling back with these patients and their nurses to make sure we were moving in the right direction. All of my ER people know this juggling act. You're moving so much and doing so many tasks that you don't actually have the time to think about yourself or how you're performing. When you're in your training, you so appreciate the backup of a good attending like Lori, who you know is there when you need them, but not hovering all over you and micromanaging every tiny thing. Looking back, I see now that she already trusted me. I have no idea what I had done by that point to gain her trust. Trust is so crucial between residents, the doctors in training, and attendings, the supervising doctors who are teaching at the bedside. Even though the attending is the physician in charge, the resident is carrying out most of the tasks for the patient, learning by doing. But if anything goes wrong, at the end of the day, it's the attending who's at fault because they are the supervisor. As a teaching attending myself, the residents know that when I start to back off on the tiny details, or if they don't immediately see me in the high acuity patient room, or if I don't talk in the resuscitation room when they get a new patient, that's a milestone for our relationship. It means I trust them. Now back to the shift with Lori. I still remember we were in Trauma 2, which at that time was a main resuscitation room for super sick trauma and medical patients. So far, our conversations on shift had only been about the patients. She was quiet but direct, and I hadn't even seen her laugh at work yet. Lori stopped for a moment and turned back to me and said, "Patil, I didn't know you had a core of steel." Taken back and surprised, all I said was, "I didn't know either." And we went on our way. But that sentence stuck with me over 16 years later, and I still think about it. I walked out of the ED that day thinking, for the first time, I can really do this. I can be an ER doctor. If Lori thinks I can, it must be true. Now we're going to fast forward to a case I had with Lori when I was a relatively new faculty member. After my 4 years of training in emergency medicine in Fresno, I moved to San Francisco to the UCSF mothership to do a 2-year fellowship in medical toxicology. After that, I moved back to Fresno to be a faculty member at the program where I had trained. At first, it was odd navigating 2 specialties, emergency medicine and medical toxicology. Sometimes I was the ER doctor working a shift. Sometimes I was the toxicologist on call, seeing a sick, poisoned patient in the hospital. When I got called to see a sick patient in the ED as the toxicologist, I was now put in the especially awkward position of telling my ED colleagues what to do. However, as the specialist, that's our job, to give recommendations for the care of a sick patient. And since this was a new consultation service in the hospital, many people didn't even know about us and frankly, didn't yet understand the benefit of calling us to see patients. Lori, on the other hand, was super supportive, as always. One Thursday morning, she was the attending on in the red zone, the high acuity area, and had gotten a really sick patient. Thursday mornings are conference mornings, so that means all the residents were at lecture and only attendings were left in the ED to see the patients. Barely a few minutes after his arrival, she called me for a consult. She never sounded stressed, so when she told me, "You need to come now," I almost ran. I walked super fast and was there within 5 minutes. She was standing in the room with everyone: nurses, respiratory therapy, techs, and in the middle of the room was a gurney with a man on it who looked like a Tasmanian devil. He was super agitated, delirious, with flushed red skin, and his skin felt really hot. The story was that he was found in a local park, acting very bizarre and not making any sense. I don't even know how our amazing medics brought him in, but they did. In the last 10 minutes, he had received a very large amount of sedating medications, but it made no change at all in his level of agitated delirium. Interestingly, his blood pressure was very low, and his cardiac tracing on the monitor looked really fast and wide, which is bad. Although there was no clear story, this combination of findings made Lori think it could be an overdose or poisoning, so she called me. Of course, someone can tell you all about a patient, but you don't know the real picture until you go and see them in person. After walking into the room, I first put my hands on the patient, and his skin felt really hot. Despite that, he wasn't sweating at all. His blood pressure was precariously low, and by some miracle, our EKG techs managed to get an EKG on him. And it looked awful. It showed something called sodium channel blockade, which basically means he had a very severe cardiac toxicity, like his heart had been poisoned. Lori was indeed right. This was a toxicology case. And now I would begin the awkward dance of trying to tell one of my old bosses what to do. Instead of making it weird, she just looked at me and asked, "What should we do first?" That meant I could take charge. I said, "Let's get his core temperature first." It was 42 degrees Celsius, which is 107.6 degrees Fahrenheit, and we can all agree that's extremely high. Then I said, "You have to intubate him now so that we can start cooling him down fast. Nothing we do is going to work until we cool him down." She quickly intubated him while I ran down to a room in the ED I knew had a fan. I brought the fan over and we started evaporative cooling while giving him lots of boluses of the antidote for this type of cardiac toxicity, sodium bicarbonate. We don't need to get into all the details, but within 30 minutes, we had him cooled to a more life-compatible temperature of 39.5 degrees Celsius. His blood pressure was coming up as his EKG normalized. The next day, he was extubated, which is when they take the breathing tube out, and he was back to normal, confirming my diagnosis of diphenhydramine toxicity. He had overdosed on over-the-counter Benadryl, otherwise known as diphenhydramine. I use this case as a teaching case every single time we have residents rotating on the toxicology service. More importantly, Lori gave me the validation that I was indeed a specialist in this other field, and that my input was valuable and needed. Afterwards, she said that she was so glad I was there and came so quickly to the bedside to help. I expressed my gratitude in being called in the first place and in letting me guide the resuscitation. Her confidence in me let me actually be confident. Now let's talk about my third formative case with Lori. In the middle of my second year of residency, we moved to a shiny new hospital with a bigger ED. As big as a football field, we heard, and there was even some funny chatter about us needing segways to get from one end to the other. The segues didn't happen, by the way. We solved a lot of the geographic issues by separating the ED into different zones, with groups of providers assigned to certain areas. The nurses were also assigned to beds that were next to each other, and each area had its own medication room and nursing station, so that they didn't need to run around the whole place. Except, we all still run around all the time. At the time of this case, I was a third-year resident, and so I had some experience under my belt, but there were many things I hadn't seen yet. Some cases, like super sick kids, are kept for the most senior residents, the fourth years. But there was no fourth year on in the department that day. So when a pediatric stat medical was called over the intercom, I knew it would be mine. Lori and I walked into Red 3, which is the name for our pediatric resuscitation room, and got ready with the rest of the team, the nurses, the ED pharmacist, respiratory therapist, tech. A lot of people squeeze into those rooms for every sick patient. And we heard that it was an unresponsive 6-month-old, 10 minutes out. So the room was packed. We wrote down on the marker board all of our medication doses, went over endotracheal tube size for an infant, talked about different scenarios. Every person knew their role in the room and was ready. 1 minute out, the medic called in to say that they had started chest compressions. It had turned into a code blue. I had never, ever ran a pediatric code before and was super nervous. No, not nervous, more like freaked out and wishing I could run out of that room. Lori, on the other hand, was cool, calm, and collected, like, we just do this every day around here, nothing to worry about. She set the tone for that room, which was, we are not freaking out here. We're handling this shit calmly. You will never know that we are nervous, so I copied it. I don't know what else to say, except I just tried to copy her level of chill. People work at their best when the room is calm, and we were dealing with a potential intubation, need for IV access, CPR, which is chest compressions, and possibly other procedures that would not go better with nervous terror in the room. The paramedics brought the patient into the room and did chest compressions while giving report. Everyone quietly listened while they moved the patient to our gurney, and the ED-EMT seamlessly took over the compressions. The story was limited. We just knew that the baby was found completely unresponsive in her crib, and at first had a good pulse, with a heart rate above 60. The paramedics immediately gave her oxygen and rushed to transport. During the transport, her pulse got slower and slower until it dipped below 60, at which time they started chest compressions. There was no IV access, but they had an IO, or intraosseous line, in her bone, and gave her 1 dose of epinephrine. To be perfectly honest, she felt very cold and looked dead. Her pupils were fixed and dilated. We gave her more epinephrine, secured her airway, continued chest compressions. Holding compressions, we could see some sort of slow, disorganized rhythm on the monitor, then would resume compressions. This was classified as PEA arrest, which stands for pulseless electrical activity. Lori and I quickly went down the list of reversible causes of PEA arrest, something every resident memorizes, and tried to check them off one by one. We checked her temperature. She was neither too hot or too cold. She had a secure airway with the endotracheal tube in place, and respiratory therapy bagging her with oxygen up to a SAT of 96% on the monitor with a good waveform. The nurses had quickly gotten IV access, and we were giving her fluids in case she was in shock. We gave her sodium bicarbonate in case she was very acidemic. We gave calcium chloride in case her potassium was very high. We brought the ultrasound in the room and looked at her heart to see if there was fluid around it that we could drain. There was not. None of the interventions worked, but we kept going because this was a baby. We kept going for almost an hour, an eternity in ER time. But this was a baby. We all wanted to keep trying. Lori looked at me, and although I'd never seen that look before on her face, I knew what the look was. It was the look of, I think this baby is dead. I can still remember every child that has died while I was in the ED. This would be my first, and it was my job to say the time of death. But first, I asked everyone in the room if they had any thoughts at all on what we missed, if there was anything else they could think of to do. The entire team shook their heads. We had done everything we could think of. And so I called out the time of death and we stopped everything. Now, normally we would call the parents into the room prior to that point so that they could see their child. Even if we knew that our efforts were futile, they could get a chance to say something to them before death. Oddly enough, there were a lot of cops outside the room, and they had already informed us that this had become a police investigation. The infant's mother was still on scene to answer questions and wouldn't be here for at least another hour. So unfortunately, we had to pronounce the death before she arrived. Lori led a debrief session with everyone in the room. We all discussed what went well, what didn't, if we had any equipment issues, basically, what we can work on for next time. We all needed it after that traumatic experience. Now, in 2023, I can't imagine having a tough resuscitation and not doing a debrief session with the entire team immediately afterwards. But this was 2008, and it was not the norm. The norm was to walk away and immediately jump into your next task. Sometimes we still have to do this if the next task is another code blue. However, Lori insisted on the debrief, and we weren't going to question that. It bonded us tighter as a team, and at least we walked away knowing that the resuscitation had ran as smooth as possible and that we had really done the best we could. She then pulled me aside into the doctor's charting room and discussed all of the finer points, while sympathetically acknowledging how traumatic it is for us to see a child die. My job wasn't done, though. 2 hours and many new patients later, the social worker informed me that the mother had finally arrived. I had to go into the quiet room and inform her that her baby had died. I had informed people about their loved one's death before, but never a child. Lori talked me through it, laying the groundwork of what I would say. Then I looked at her like, "You're coming, right?" And she said, "No, you can do this. You're going to do this." I went with the social worker to the quiet room, and it was the two of us and the patient's mother. I went through everything and finished with the news, using the D word, dead. The mother sobbed and screamed and sobbed. We hugged each other, and I'm pretty sure I cried too, or probably sobbed. Then she said something I'll never forget. "I already knew she was dead because my titties dried up 2 hours ago." She was breastfeeding and hadn't made milk since the infant's time of death, so she already knew what I was going to tell her, but it didn't lessen the horror one bit. After that, I knew that I could do really, really hard things. How can I possibly summarize what Lori taught me? In one sentence, I'd say, we can all do really difficult things, and we can do them better if we have the tools to take care of ourselves. I'm so grateful to have known her, and I'm honored to have been a part of her life. Thank you, everyone, for listening. I'll see you next time. Please like, subscribe, share, and download the podcast. And again, you can find us at Human School Podcast on Instagram. I'd like to thank Dr. Zach Effron for the theme music. And I'd just like to make a general disclaimer that any of the institutions I work for, including Community Regional Medical Center, UCSF Fresno, and American Ambulance, have nothing to do with any of my thoughts or opinions, and so we'll kindly leave them out of this. Thanks, everyone. See you next time.